Welcome to Medical Evidence Matters with me, Liz Tucker, the podcast formerly known as What Your GP Doesn't Tell You, aimed at doctors and patients. In this week's episode, I'm talking to psychiatrist Dr Alastair Santhouse, who's concerned that the huge increase we're seeing in mental health diagnoses is now medicalizing emotions and feelings that had previously been seen as just part of the normal human experience. Not only, he argues in a recent book, No More Normal, Mental Health in an Age of Overdiagnosis, published by Granta, has this led to a substantial rise of people on medication. Today, in England alone, over 8 million adults take an antidepressant every year. But it's also led to an unprecedented demand on health services, increasing waiting lists, which risks leaving those with severe mental illness who really need the support unable to get it. But before we get to Alastair's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com or via PayPal on my website. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. Now back to Alastair's interview. Dr. Alastair Santhouse is a consultant neuropsychiatrist at the Maudsley Hospital in London. Before retraining to become a psychiatrist, he practiced hospital medicine. Alastair is a fellow of both the Royal College of Physicians and the Royal College of Psychiatrists. Here's his interview. Alastair, thank you so much for joining the podcast today.
Well, it's a pleasure to be here. Thanks so much for inviting me.
Now, Alastair, in your book, you say that diagnoses for many mental illnesses have increased rapidly since you qualified in the 90s. And yet our knowledge about these diseases has not increased by anything like the same amount. So why are psychiatrists diagnosing so many more patients than before?
Well, I think the first question is it psychiatrists diagnosing them, or is this diagnosis coming in the round from all sorts of places, from GPs, therapists, and other sort of allied professionals to provide an increase? And the question as to why, I think, is the sort of million-dollar question, which is, why are we seeing this? And there's lots of different perspectives that people bring in. And I brought my perspective from a career lasting 30 years in April in psychiatry.
Of course, there's many different groups who are involved. But if you look, for example, at the Psychiatry Manual, the Diagnostic and Statistical Manual of Mental Disorders, the latest version is DSM-5, so the fifth version. And when it was first published, I think it listed around 100 psychiatric conditions. Today, that figure has gone up to around 400. Now, of course, in all areas of medicine, we see an increase in the number of diseases recognised as science progresses. But no other area of medicine, I think, has seen anything close to that increase. So why are so many conditions being added?
I think the splintering of conditions that we already have is, I think, part of it. And then I think we often see the addition of various other diagnoses that didn't used to exist. And I think in part it's because the way diagnoses are conceptualized. You could imagine on the one hand that you have diagnoses that exist independently of you and me. You could imagine, let's say, a chest infection. Everyone would agree that whether or not you knew about bacteria or anything like that, a chest infection is a chest infection. You get to treat it. I think on the other end of the spectrum, medicine, you might have pain symptoms where sometimes the organic nature of them is much less clear, where we're not quite sure where they begin and end, where you have to start using judgment. Or hypertension, how much is hypertensive? And does it matter if it's 10 millimeters of mercury more or less? There is a certain sort of judgment in that. I think if you translate that into psychiatric diagnoses, I think there are some where in any generation, in any time, you would probably recognize something called psychosis. You may or may not call it schizophrenia, but you'd have an illness with psychotic symptoms or manic symptoms. You'd have something that looks like depression. But I think there are some diagnoses that you'd think, well, would they reappear? For example, behavioral addictions. Sometimes that might be a gaming addiction or smartphone addiction. And you think, well, what are those? Would they exist independently of us? Are they, quotes, real diagnoses? And how are they defined? Are they sort of socially defined? Or are they expressing some sort of underlying biological factor? And I think there's a lot of debate, both about those diagnoses, but about the limits of the diagnoses we do have. How sad do you have to be? How many symptoms do you have to have before you can be called depressed? We don't have a blood test. We don't have a scan for it. So there is an issue there, a certain subjectivity. Yes, it's decided by committees of experts and put into categories like DSM, but ultimately it is a judgment. I think no one would mistake severe depression for anything else. It's obvious that people are often moribund, not speaking, not eating, not drinking, sometimes delusions and hallucinations. And then you have milder forms of depression that I think can start to overlap with normal variation. And the extent to which that is the same organic process is a question.
And also a question, I guess, whether mild depression is a medical illness or part of the human condition.
Well, I think that's a really interesting and important question. And, I talk about overdiagnosis in the book, and it's not as a means of denying people their suffering or to tell someone that what's happening to them is trivial in any way. Of course, I'm not saying that, but I'm saying that whether the conceptualization of things as a mental illness is a helpful way of framing it. For example, we know that in society, there's a lot of loneliness. People might be facing financial worries, housing insecurities, job insecurities, relationship difficulties, unemployment. They might feel each day getting up, there's nothing ahead, nothing to look forward to. It might make them feel sad, disappointed, hopeless, a bit despairing. And if you look at that superficially, you could say, well, that all looks like depression. But actually, it misses the point. I think that distilling down someone's wider issues and calling it depression and then trying to put them down a pathway of medication treatment, for example, isn't what those people would need. Antidepressants in those situations, it's unlikely that they would really work because the point might not be about depression. I mean, obviously, they may become depressed as well, but I'm saying that a lot of people, what looks like depression might not be. There is a view that making a diagnosis might be quite easy, that someone just needs to declare they're depressed and somehow someone will endorse that diagnosis. And I think even for diagnoses like depression, I think it needs to be done rigorously. The psychiatric interview is meant to be rigorous hypothesis testing of trying to place someone's symptoms in the background of their life, understanding their social circumstances, their habitual thinking processes, the way that they understand and manage their emotions and problems. There's a whole lot to think about before you would want to apply that label to someone and put them down a treatment pathway. And I feel that the increased diagnosis, I think, might reflect something of the fact that that's not always happening.
But is there also, and I can't really think of another field of medicine where you've got exactly the same situation. In psychiatry, there are various schools of thought, psychoanalytical, whether it's believing that social problems play a greater role, or whether it's people who perhaps come from more sort of conventional psychiatric background, as you do. And all of those different perspectives tend to affect how they see those diseases.
Yeah, I think people's sort of background and training does colour how they see that kind of thing. And I do worry occasionally that there is a risk of guild warfare sort of breaking, or warfare might be overstating it, but
Don't think it is in some things I see on Twitter, actually, or X.
But the sort of sense in which people think that their view needs to be the sort of dominant or right way of looking at it. When I was training, psychiatry was always taught as a biopsychosocial specialty. yes, there was a biological reality to a lot of the mental illnesses that we were diagnosing, but that in itself wasn't enough. There were psychological factors, people's habitual ways of perceiving, understanding, and interacting with the world, and the social factors. And the psychodynamic and the upbringing and all of those, I think, are different facets of the same thing. And to try and just chisel one of them away and say, well, this is the way that we need to be looking at it, is why these problems develop.
But this idea that we may be medicalizing perhaps what is part of the normal human condition, some people have also criticized the manual for. I think something that got a lot of publicity at the time was prolonged grief disorder. And if you actually read the manual's definition, I've got it here, it said, prolonged grief disorder is a diagnosis for intense, persistent grief that lasts for at least 12 months, 6 months for children, following a loss. Criteria include persistent, intense yearning or preoccupation with the deceased, occurring most days for at least 1 month. Now, to me, that sounds a completely normal reaction to the intense emotions you feel when someone you love dies.
I think one of the most controversial changes in DSM-5, which is the current iteration of the Diagnostic and Statistical Manual, this sort of psychiatric manual that we're talking about, one of the most controversial was about whether depression could be diagnosed in the context of a bereavement. Now, there used to be something called a bereavement exclusion, so that you couldn't diagnose depression within, I think it was 6 months of a bereavement. And that exclusion was dropped. And there was a great outcry. And I think it said something to people of exactly what you're getting at, which is, as one paper put it broadly, if I remember correctly, but something along the lines of the intrusion of bureaucratic standards into something that everyone had hitherto accepted as part of life. That was something important about the grief and going through the grief, and to want to label it in some way as normal or abnormal, or that they were really just depressed, a lot of people found unhelpful. In reality, you don't really see much of a clinical problem with it. I don't get referred people hardly at all with abnormal grief reactions or that sort of thing. But I think it said something that the public related to about where these boundaries should be drawn. And it's what we were talking about a little bit ago about conceptualization of diagnosis. Now, you would have grief reactions ever since there's been human beings, and you would have mood reactions in the context of that. But understanding them as abnormal or understanding them as depression is surely a socially influenced aspect rather than something separate and biological. It comes back to that framing of how we understand and conceptualize psychiatric diagnoses at all.
Another issue which you've slightly touched on is that inevitably a psychiatric diagnosis has a level of subjectivity that other levels of medicine don't. You know, if you test for high blood pressure, you've either got high blood pressure or not. Whereas in psychiatry, there isn't a test to say somebody's got one particular disorder as opposed to another.
I mean, I think there's a broad truth in that, but I think if you find something like chronic fatigue syndrome, you don't really have a test for that either. You have to use a judgment. You have to take at face value.
And that becomes more controversial, therefore, doesn't it?
Well, I think so, but you would take pain syndromes or chronic pain, and again, ultimately, all you have is a subjective report of someone's pain, and you have to sort of take that at face value. I think that psychiatry is not unique.
I don't think it's unique, but I think there are other areas of medicine where that would apply to certain conditions.
Right.
Whereas, as far as I'm aware, it sort of applies to all conditions that psychiatry looks at.
Yes, I think that is true. Again, it comes back to what I mentioned before, which is at the severe end, I don't think you could mistake psychiatric, severe depression or a psychosis or a manic episode. I don't think you could really mistake that with anything else.
So do you think it's a spectrum of behaviour? When you say you couldn't mistake, and absolutely, I understand that. Somebody's got acute psychosis, schizophrenia, you're not thinking these people are not seriously ill.
Yeah.
But is that then a spectrum of behaviour, or are you actually looking at different conditions?
It's different ones. I mean, Take something like OCD and you think, well, how many times do you have to go back and check the gas tap in your house or rattle a front door before you say, well, that's just too many? Whereas I think something like a psychotic symptom is a difference in kind rather than a difference in degree for the most part.
As you said at the start of our chat, it's not only psychiatrists diagnosing more mental illness, but it seems to be patients are much more likely now to do that for themselves. And one thing the doctors frequently comment to me is that patients are now much more likely to come in with a self-diagnosis for mental health. So how do you deal with that?
It can be very difficult. I mean, I think on the one hand, I think we would all applaud the sort of the fact that stigma in psychiatry is not what it was. As I mentioned, I sort of qualified in 92 and I moved into psychiatry in 96. And over that time, I've seen the reduction in stigma, and that can only be to the good. But I think there is something about our current conceptualization of suffering and distress. And again, I feel the need to stress, I don't ever doubt people suffering when they're telling me. But the conceptualizing of it as a mental illness is, I think, quite new. I think it's in part reflects the sort of reduction in stigma, but also something about how in our generation, how we think about these things. I think there was a 2015 survey in the National Union of Students, and I think it said something like 78% of students reported to their union having had some kind of mental health problem within the past year.
It's an extraordinarily high statistic, isn't it?
So it's high. I mean, I'm not saying that they all said that they were mentally ill. And again, there is this sort of blurring of what does it mean to have a mental health problem versus what it means to have a mental illness. And I'm not sure exactly what was meant by that. And of course, as far as I'm aware, it was a survey. I don't know exactly the methodology of it.
Because I'm sure you and I can think when we were students, there were moments when we might have felt sad, but we wouldn't have characterized that as a mental health problem.
Yes, absolutely. I remember at university, there was a pamphlet came around one time and it was called The Blues. And I took it and I related to all of those items in it. And, medicine was a hard degree and, everyone else was out having fun and I was, sitting at my desk half the time and I felt just heroically sorry for myself and felt sad. And I wonder now, looking back, whether or not someone would have said, yeah, you're depressed and here's some medication. And it didn't really at that point cross my mind. It did subsequently.
It's interesting. University professors have also said to me that how students come in and self-diagnose with multiple mental health conditions. Whereas when I was a student, and I'm sure for you too, it would have been unheard of for a student to do this. I can't imagine how my tutor at university would have reacted if I'd gone in and done that, probably fallen off his chair, I suspect.
Yeah, we are in a different cultural moment. And again, I would say it's a good thing not to have stigma anymore. But I think that the more it's talked about, there's become what's called a looping effect, where people start to wonder if it applies to them. I think it feeds back into how the diagnosis is thought about and made by others. In other words, I think it starts to dilute the criteria under which diagnoses are made, which leads to the view that it's really very common, which leads to more awareness raising campaigns. And there does seem to be a factor of how, if you like, the language of psychiatry is escape psychiatry, if I would put it like that. And I think that that's again a factor. We talked about a sort of cultural understanding, but I think there's also this looping. And I think there's also this notion that diagnosis might be easy and subjective and you just need to declare it. And you have a whole range of factors all pointing in the same direction now. My concern is that I don't think it's necessarily healthy for people. If people criticize me, which they might do for raising this about overdiagnosis, it's often in the framing of it's unkind, that you're removing or denying somebody something. And I really want to stress it's not about that. I do appreciate that sometimes people are suffering, but whether the framing is correct and whether labeling someone is really a helpful thing to do for them, where that label might not necessarily apply. I mean, I once heard a professor of psychiatry and I was training, he said something like labels are sticky labels in psychiatry. I think people can define and even start to limit themselves.
Because if somebody thinks they've got a mental health condition or another, and therefore they start to see themselves as permanently mentally ill and less able to function. That's not necessarily going to be very helpful for their long-term health.
I would say that's true. And I think it was the Health Foundation, although I can't remember exactly. But there was something about the number of young people now who were unable to work because of mental health. And it sort of limits the type and amount of work that they could do.
Yeah, it was the Health Foundation.
Right. I mean, obviously, someone with significant mental illness is not, and I do appreciate that, not going to be able to work. But I wonder whether this labeling is having an effect. I think it's something to be considered, because if you're young and not able to go into work, that might predict difficulties in the longer term.
And ironically, not very good for your mental health.
I often have that conversation with patients, the extent to which they can. I always try and encourage people back into work because I think it gives them a purpose, a distraction, a social interaction, a structure, lots of things that I think are mentally very healthy for people generally.
I've got a note here on the Health Foundation, actually. It said that mental ill health is now the commonest cause of work-limiting conditions for those under 44. What I found, most concerning was more than 4 times as many young workers report that their mental health affects the type or amount of work that they can do than was the case a decade ago. Well, if that trajectory continues, where does that lead?
I mean, I think it leads to the sort of conversation we're having now, which is, as a society, are we getting this balance right? As I said before, there's always a notion that endorsing and labeling is the decent and kind thing to do. But I think we have to ask that question. Have we got this balance right? Are we doing the right thing? You could argue, or it might be argued, that we really are seeing an increase in mental illness for reasons we don't know. Rates of depression seem to be increasing more or less year on year. Antidepressant prescriptions, I think, were, if I remember correctly, about 36 million in 2008. I think it was one BMJ study.
I think it's about 1 in 5 adults now taking an SSRI.
On the one hand, you could argue that something about our society is so rotten and toxic that explains it all. Or you could say that what is counting as depression, maybe at the milder end, being treated with antidepressants, we're not necessarily doing the right thing by people.
Do you think it's possible to think yourself into poorer mental health?
I mean, that's a really good question. And I think the answer is quite sort of nuanced on that. I think on the one hand, if you have a notion that you've got a mental illness and you start to see everything through that lens and start to become more withdrawn and stop interacting or socializing, I'm sure that can start to change the symptoms that you experience, and that might become self-fulfilling. I don't know the answer exactly. I don't think you could think yourself into a formal mental illness, but I think the way that you understand and appreciate your health probably impacts on it. In the same way, I think we probably do it with our physical health. If we injure ourselves, we have to make a judgment about how serious that injury is. Do we stop moving that bodily part? And if we do, after a while of disuse, does it actually make it more painful for us to start doing that, and reinforces our idea? I think there is a parallel with how that might happen. So I think the question's an interesting one.
I'm thinking, for example, of mental health awareness campaigns. I had the neurologist Dr Suzanne O'Sullivan on the podcast several months ago, and she quoted a study from the Department of Education in February, and it was a mental health awareness scheme, and she was contrasting 2 groups of school children. One was given mental health awareness, one group was not. And after 12 months, the kids who'd been given the mental health awareness training had worse mental health.
Yeah, I'd heard that as well, and I don't think it surprises me. For example, for something like trigger warnings, as far as I understand, the evidence suggests that it makes people worse. When they see the trigger warning, it reinforces their sense of identity being bound up with a trauma. It causes anticipatory anxiety. I still see it all the time because it seems like the kind and decent thing to do. It seems self-evident that you should do it, and yet the data doesn't really support it. We used to have the same thing with compulsory debriefing after traumatic incidents, that people assumed that if you'd gone through a traumatic incident, the best thing to do was, so to speak, lance the boil and get someone to talk it through. And it seemed to be the case, I think there was a Cochrane review about this, that it tended to be counterproductive. And I suspect what it did was, rather than allow people to process that memory and work through it and even forget some of the details about it, it seemed to maybe reinforce the memories of it.
And in fact, yesterday on X, there was a post talking about an ADHD awareness campaign, which seemed to have reported the same thing.
Yeah, I think there is something to be discussed there. And I would just make the point that campaigns always seem to be about raising awareness and never about the harms of increased diagnosis. And there are harms, and we've talked about some of them, about people being limited, about its effect on self-esteem, opportunities, and these are not trivial things.
And in fact, ADHD is one thing that you do mention in your book, disorder which is hugely increased. And I think you said that a UK study showed that the prevalence of drug use in children increased 34 times between 1995 and 2008. So I suppose, again, with that, is there a risk that, therefore, for the children who are really struggling, that you've sort of devalued that?
I have to say, number one about that is I have worried about public confidence in our ability to differentiate illness from normal variation. It's not something that I've highlighted very much, but I wonder where the public are with this now. You know, I've come across sort of comedy sketches or people joking about these neurodevelopmental diagnoses. And, you know, obviously for people suffering from them, they're no laughing matter. I'm concerned about public confidence. I mean, there was one study that showed for children, there was an excess of diagnoses in August birthdays, where the school year starts in September, because immaturity was being labelled as ADHD.
So therefore, they find it harder to concentrate, they fidget more because they're younger.
Exactly. And it's a worry. And I think one of the biggest increases in diagnoses, if I look at my career as a whole, I think probably the biggest increase has been in new onset adult ADHD. It was really quite uncommon 20 plus years ago, and now is really very common indeed.
Because we always thought, didn't we, really, that it was a disease or a condition of childhood. There certainly seems to be some sort of cultural interpretation, because in some states in the US now, I think 1 in 8 children are being diagnosed as ADHD. Tends to be lower in European countries.
I mean, I think that tells a different story as well, which is if we're uncovering diagnoses that we should have picked up, and I don't doubt that some of this increase, by the way, is in us uncovering people that we ought to have picked up. But I think some of this uneven increase in diagnosis is telling its own story. If we were uncovering that and just that, you'd expect there to be a far more balanced rate worldwide and even within countries, but we're not seeing that. We seem to be seeing an increase that isn't plateauing. This uneven rate, the fact that the prescription of medications is uneven as well, and in some countries reflects affluence as much as anything, and it gives you pause for thought. To what extent are we uncovering a biological illness called ADHD, and to what extent is this something else? I think we've always understood that there is an entity called ADHD, which is a neurodevelopmental disorder, and we've always understood that many children will, as their brains develop, this neurodevelopmental disorder will dissipate, subside. But for some people, it will persist. So the rate of persistence, it varies depending on which study you talk about. But let's say in its full form, maybe 5-6%, and in a milder form, another few percent will persist. So we know that some will persist into adulthood, and some are probably being picked up who were never picked up in childhood and are now in adulthood. But one study looked back at people diagnosed for the first time in adulthood and went back to childhood records and didn't seem to find evidence of a neurodevelopmental disorder looking back. I think it was around 90%. It makes you think, well, what are they picking up? Because one thing we haven't really or maybe we talked about at the very beginning, which is that a lot of the symptoms now are quite broad and common. So inattention is part of a lot of psychiatric disorders, not just ADHD. Not wanting to finish tasks that are quite boring or not taking on tasks that require sustained mental effort, I think is quite common to do. So you have a broad range of symptoms that are relatively common in the population, can reflect other states like anxiety, bipolar disorder, personality subtypes, possibly normal variation. And a lot of these, I think, are being subsumed into an ADHD category. And I'm not sure that the evidence bears out the prescription of psychoactive medications as effective for a lot of these people. If you work as a psychiatrist, you deal with descriptions of symptoms, you try and sort of make sense of someone's symptoms, again, in the context of whether it could reflect their personality, other mental health problems, of normal variation, the context of someone's life. And I think the other issue that I don't think really gets talked about particularly is, we call ADHD and the D at the end is disorder. And the question there is, to what extent is it a disorder? If it's not really impacting on someone's life, then is it a disorder at all? And can we make the diagnosis under those conditions? These are all questions I think we as a society need to try and resolve.
But it seems to me one of the biggest problems, if so many people are going to be diagnosed and think they need treatment, not only is there a risk that may minimize these conditions, the risk is surely it simply overwhelms the healthcare system, and those people who really need the support can't get it.
Well, we've already seen evidence of that, I think, in the waiting lists for autism and ADHD assessments. It was reported about a year ago that the waiting list for ADHD assessments in some areas was measured in years, not months. And the system is being overwhelmed, and I think it is a concern. We live in a time of limited resources, and we have to allocate it as best we can. And if a lot of resources are being used for this increase in diagnoses, it causes a problem, including waiting lists, but also for all of the time that there's been an increase in a number of these diagnoses. I think the diagnoses of schizophrenia and severe mental illness will be relatively stable, and we need to make sure that they don't get overlooked.
In the same way that the diagnosis of severe autism has not changed very much, but there's been a huge increase in the diagnosis of more mild cases.
I think that's right, and I think autism is another example. I was going through an old handbook of medicine, one of those ones you could keep in your pocket as a junior doctor on the wards as pre-internet, as a bit of reassurance. And I came across the couple of these sort of rice paper pages on autism, and it said that it was a rare illness, and I think it quoted 2 in 10,000. And I think it said something like 50% of people would develop useful language, and about 15% of people would be able to lead an independent life. We understood autism 30 years ago as a very severe, disabling illness, commonly associated with learning disabilities. We understand it in a very different way now. And 1 in 30 is broadly the figure that you hear now about how many people have this diagnosis. And I think you hear from many of the people whose children are at the severe end that they feel increasingly left out of the conversation.
What's the future for this, Al? Because if these trajectories continue and they're not plateauing, and we have more and more people who, for example, feel they can't work due to mental illness, and more people who feel for various other reasons that they can't function, that seems to me a rather depressing future.
I think that's right. And I think that's why it's so important to start having these conversations without a good faith conversation, let's say, where you're not trying to remove something from someone, you're not trying to deny someone the difficulties or suffering that they're going through, but you ask yourself, is this helpful for you, this framing of this as mental illness? I think a lot of consultations I've had where it's been a successful conversation is when I've told someone they don't have any mental illness or mental health problem. And it's important to be able to say that. I understand that you're going through a difficult time, but I don't think this qualifies for what I would consider mental illness. So we need to be having those conversations. And the question is, how do you have a good faith conversation now in the current sort of cultural climate about these things without it becoming someone winning and someone else losing?
You're absolutely right. And I wonder what we can do on a societal level, because if indeed the mental health awareness campaigns, at least some of them, appear to have a risk of backfiring, but yet this is seen at the moment as rather an attractive initiative. Are there things there that we need to change?
Well, I'm not sure what we do about that, because you don't want to be against awareness, but you want to make sure that there are boundaries to diagnostic thresholds. I mean, we talked about the cultural aspects in the last few minutes, but I think there are a number of other things. One is whether the new iterations of our diagnostic guidelines need to be tighter. We have to have that discussion about, do you run the risk of missing people out of a diagnostic category but having it much more tightly defined? Or do we want this very broad category that includes people who in many cases don't need to be there? So I think removing diagnoses where they've been shown not to really offer benefit, I think again is something we need to consider. Some people have talked about whether we should have symptom-based rather than diagnosis-based classifications, and there is some work being done on that. Maybe in the longer term future, we'll be able to bring more biology to our diagnoses by more advanced scanning of ways of seeing brain changes, and people have been doing that as well on computational psychiatry. So I think there's a distant future where we might have different classifications and ways of understanding symptoms. And there's a more sort of social as opposed to biological future where we do try and realign what we understand by mental illness and try and have a consensus and see, you started off this very interesting conversation with the rise in the number of DSM diagnoses. We need to understand why that is and whether we should start cutting them back now. How many of them are really valid? I see something suggested like smartphone addiction. And the first question people ask is, well, how bad is it? How common is it? Rather than, is this a meaningful and valid diagnosis at all?
Is it stopping me going to work, earning a living, and all of the other things we might think an addiction might do?
I think that's exactly right. I notice that during any 2-second lull in a conversation, I'll whip my phone out my pocket. It's a reflex, and it's probably not a very endearing one. But it's not only me that does that, and that doesn't, I think, translate into addiction. So these things, I think we need to be discussing.
Finally, if you were advising the NHS, is there anything further you think it can do that would be helpful?
I'm not sure. Maybe there needs to be a further discussion about this. I think there are discussions about this and the direction we're going in. I don't think it's easy, because I don't think it's easy to change a culture. But you mentioned you've had other guests on your show as well. I think people are starting to talk about this now. And I think perhaps that's how cultures change.
Well, Al, thank you so much for talking today. Really interesting. Thank you.
Thanks so much for having me on.
Goodbye.
Bye.
Hope you enjoyed the latest episode of the podcast. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.